The anatomical differences in the infant chest make evaluation of pulmonary disease such as tuberculosis difficult. Firstly, the cardiac silhouette is enlarged. And in the infant, the cardiothoracic ratio can be up to 0.65 or 65%. In addition, the thymus is sizable, and along with small pulmonary vessel with the enlarged thymus and cardiac silhouette make evaluation of adenopathy and perihilar consolidation very difficult. As mentioned, the thymus is enlarged in the infant. The thymus has different morphology in the infant. In this case, the thymus is a bilobe structure, and the thymus in this case is symmetric, as outlined here. The thymus can also be asymmetrically enlarged. This is the classic cell sign where the right lobe of the thymus is asymmetrically enlarged. Similarly, the left lobe of the thymus can also be enlarged, as outlined here. And the thymus can have an elevated appearance in this particular case. Now, it's difficult to obtain a full inspiratory effort in an infant as they cannot follow instruction. And often the chest radiograph that we obtain in an infant are with low lung volumes. When that happens, the trachea is elevated and buckled to the right. Now, with the enlarged thymus on the right and the buccal thymus, the buccal trachea, the impression is that there might be atelectasis involving the right upper lung, but this is not so. This is only secondary to a very low lung volume. Similarly, when there is diagnostic question regarding possible atelectasis on the frontal chest radiograph as seen previously, a lateral can be obtained if possible. The thymus, sorry, not sure why my, okay, all right. On the lateral projection, yes. On the lateral projection, the inferior border of thymus is horizontal, as demonstrated here. In the setting of consolidation, the outline of the inferior aspect of the consolidation will be concave. Similarly, with atelectasis, the inferior outline of the atelectasis will be convex. The lateral border of the thymus can also have an undulating appearance, as seen on this animation. This is known as the wavy thymus sign, and the lateral border, the wavy border, is created by the impression, by the reflection of the anterior ribs. As the child grows, the thymus regresses. And by 2 years of age, we begin to see the bulges of the aortic arch and the main pulmonary artery. By 3rd year of age, you begin to see the azygos vein on the right, just above the right upper lobe bronchus. And by 5 years of age, you can see that the azygos vein is well defined, and the aortic arch as well as the main pulmonary arteries are clearly seen. And therefore, evaluation of the lymph node, enlarged lymph node in the aortical pulmonary window is it can be easily performed. By 9 years of age, the anatomy of the mediastinum and hilar region are very similar to an adult. Now let's proceed with abnormal TB chest findings or radiographic findings in the child. The common findings on a chest radiograph in a child with regard to infection or tuberculosis are atelectasis, consolidation, and adenopathy. Those are the three common locations. The next three common findings are bronchial narrowing, nodule, and lung hyperinflation. And pleural effusion is relatively rare. In review of the literature, 8 studies were reviewed. All these studies have mean ages starting at 6 months and up to 8 years. As everyone can see, enlarged adenopathy, consolidation are very common findings. Similarly, on CT, the findings are the same in that mediastinal adenopathy and consolidation are very common from 6 months to 8 years of age. Bronchogenic nodule, disseminated nodule, and bronchial narrowing are better seen on CT than chest radiograph. Here is a 2-month-old TB case. You can see that the patient has diffuse parenchymal opacities. Although evaluation of hilar adenopathy is very challenging in this case, this is because the patient is rotated, as you can see by the displacement of the sinus processes. When we repeat the study with better positioning, you can see that on the right side there is perihilar consolidation as well as a very full hilum on the right. In addition, you begin to see diffuse micronodule throughout the lungs. On the lateral, the consolidation is visible over the heart. Adenopathy is also clearly seen on the hilar radiograph, on the lateral radiograph. This patient also has a CT to evaluate the type of lung nodules that was seen on the chest radiograph. Outlined to the right of the vasculature is an area of necrotic adenopathy. Anteriorly, you see the thymus, part of the thymus anteriorly. Posteriorly, you can see an area of consolidation that are fairly dense, that are fairly bright. This is atelectasis and not consolidation. As you come down, you begin to see necrotic consolidation near the right hilum, as well as additional adenopathy. Posterior to the necrotic consolidation, you also see atelectasis. Further down, again, anterior adenopathy, posterior consolidation, necrotizing consolidation. Note that the consolidation is quite heterogeneous. It has a mixture of necrosis as well as atelectasis. On the lung window, you can see that the patient has diffuse small lung nodules. A lot of these nodules stud the peripheral pleura. This is classic for random nodule caused by disseminated hematologic dissemination of the infection. Nodule along the pleura. On this slice of the CT, you also see an area of consolidation that have a small cavity within it. Now, as the child, so that was the findings on an infant. Before we proceed to evaluation of an older child, I want everyone to have a systematic approach to the interpretation of the mediastinum and hilar region. It's best to evaluate the contour and be familiar with the various bulges that form the mediastinal contour. So, for example, we talk about the aortic bulge, the main pulmonary artery, the acidus vein, and the cardiac silhouette. In conjunction to evaluation of the mediastinal contour, it's also good to evaluate the airway, to look for bronchial narrowing, looking for evidence of obstruction, etc. And finally, look at the hilar contour. With regard to the pulmonary hilar, the hilar region is composed of both airway and vasculature. The schematic in green denotes the pulmonary veins. Remember, this is a key point. Remember that the pulmonary artery should be tapered as it proceeds inferiorly. It resembles, to me, a carrot, okay, with the tip having additional pulmonary vein branches. Now, when the pulmonary arteries are no longer in the shape of a carrot, for example, if it begins to look lumpy, bumpy, as in potatoes, you know there's adenopathy present. Here's a case of a 4-year-old with TB. On the right hilum, we no longer see a carrot, correct? What we see is lumpy, bumpy, that look like a potato. This suggests that there's adenopathy present in the right hilum. The lateral confirms it. Let's go over the lateral anatomy. Anterior to so this is the trachea. This is the right upper lobe bronchus. Anterior to the right upper lobe bronchus is the right pulmonary artery. Posterior to the right upper lobe bronchus is the left pulmonary artery. And inferior to those anatomical structure is an area of adenopathy, as seen on the frontal chest radiograph. Here's another case of a 34-month-old with TB. When you evaluate the right hilum, again, you don't see the normal tapering of the right pulmonary artery. What you do see is an enlargement on top of the pulmonary artery, as well as in the inferior aspect of the pulmonary artery. On the left side, again, you don't see a nice taper of the pulmonary vessel. There are small adenopathy present within the left hilum. In addition, in the left lower lung region, there are area of multiple small nodules. On the lateral projection, again, you don't see a nice right PA as in the previous case. You don't see a nice left PA as seen in the previous case. What you see is increased density overlying the hilar region, consistent with adenopathy. Additionally, you see small micronodule in the left lower lung. This patient is 6 years old, and again, on the right side, you see normal tapering of the right pulmonary artery. However, on the left, you see an increased density in the left hilum, as well as an area of consolidation just lateral to the left hilum. Additionally, you also see small nodule in the left upper lung, as well as an area of small nodule in the right upper lung. On the lateral, again, you see the trachea, the right upper bronchus. The right pulmonary area is normal. However, on the left, you have increased density within the left pulmonary artery, consistent with left hilar adenopathy. In the anterior upper lung, you see an area of small nodule and consolidation as seen on the frontal chest radiograph. It's a complex case of a 7-year-old with TB. In the right hilar region, you have an area of increased density, as well in the area of the right paratracheal region, representing right hilar and paratracheal adenopathy. In the region of the left lower lung, you see small cluster of nodules and consolidation in both the right lower and upper lung region. On the lateral, remember this is the right upper bronchus. Anteriorly, you have increased size of the right pulmonary artery region, as well as in the left pulmonary artery extending inferiorly. This area is consistent with right hilar adenopathy seen on the frontal chest radiograph. Additionally, you also see area of consolidation and micronodule in the upper and middle as well as the lower lung. This patient has a CT. The patient still has some remnant thymic tissue, but on the right hilar region, you see increased soft tissue consistent with adenopathy. Again, in the right hilar region, additional area of increased density consistent with adenopathy. Now note that this adenopathy is very subtle, and therefore the finding was somewhat subtle on the frontal chest radiograph, particularly near the hilar region. On the lung window, you see small cluster of nodule throughout the lung. These are central lung nodules. These nodules do not touch the pleura, so these nodules are formed from inside the airway. Further down, you start to see area of consolidation in the right anterior upper lobe, as well as the right middle lobe. Finally, in a 15-year-old TB case, the finding in adolescent chest radiograph resemble adult cases where you see cavities and adenopathy. This is consistent with post-primary TB. The TB in a child or infant are typically primary TB, and therefore you see consolidation and adenopathies more commonly. The lateral confirmed the right hilar adenopathy. as well as the right upper lung cavity. Now, this patient is a 12-month-old patient that has a large right pleural effusion. The effusion does not layer in a normal pattern, i.e. forming a meniscus, suggesting that this effusion is likely loculated. The patient also has parenchymal consolidation involving the right lung. So the question is this TB or not TB? And the answer is, this is MRSA empyema. And the reason is, TB pleural effusion is very uncommon in children with TB. Tuberculosis pleural effusion are rare in young children, but are more frequent in adolescents and in boys. Most are unilateral and typically associated with parenchymal disease.
Well, thank you very much, Dr. Vu. That was a great review. That was an amazing review. And Dr. Vu, can I just send you all my pediatric TB radiology films now so I don't have to worry and stress? I wanted to reinforce a couple points. Thank you. I want to reinforce a couple points that Dr. Vu taught us, sort of from the clinical standpoint. So lots of times we'll hear about children and we'll hear about interpretations maybe from adult radiologists, and maybe the findings will be subtle, and maybe we don't have Dr. Vu in our back pocket. And a couple things I think will help all of us think about whether a child has tuberculosis or not. The first thing Dr. Vu mentioned probably 20 times is adenopathy. So, and in the table he showed, we saw that adenopathy is a very common feature, intrathoracic adenopathy, a very common feature of pediatric tuberculosis. And the way that you confirm that that lumpy bumpiness you see on your frontal view is caused by adenopathy is by always obtaining a lateral film. National guidelines suggest that if you have limited resources for evaluating pediatric TB suspects, that for sure you should make sure in the 5 and under year age group that you make sure to check the lateral. But frankly, I get a lateral for all my pediatric patients. And interestingly, the lymphadenopathy is more on the right side. So 2/3 of the time, even when the parenchymal changes are maybe on the left side or bilateral, it's more often to see the adenopathy on the right side. So that's a little feature that you can look for. And then most of the films that Dr. Vu showed, you know, I won't say that they were all super dramatic, but they weren't super subtle either. So I think more often than not, especially people who aren't used to treating tuberculosis and adult radiologists, when you say positive skin test or positive IGRA, is this TB? Well, nobody wants to miss it. And so sometimes we get readings that are maybe more subtle findings. So I always look for the classic things. I look for not terribly subtle. I look for the adenopathy. I look for the exposure risk. I look for maybe a positive skin test or positive IGRA. You're really doing your patients a disservice if you're seeing very subtle abnormalities that could easily be caused by other things, like reactive airways disease or community-acquired pneumonia. So really try to not overcall. And the next comment I want to make before we move on to the next section is Dr. Vu showed a couple of CTs, and I'm also going to show a couple of CTs, but I do want to emphasize that CT scans should not be anywhere near routine for evaluating pediatric TB suspects. So when I think of obtaining a CT scan, it's really when we wonder if there's something else in the differential diagnosis. So like especially for a patient who's immunocompromised, or you know, maybe you think, oh my goodness, that could be malignancy. But if it's TB, or community-acquired pneumonia, do not get a CT scan. It's a waste of resources and radiation. And if you are ordering a CT scan, and I hope Dr. Vu agrees with me, I didn't ask him ahead of time, but if you're looking for intrathoracic lymph nodes, you need to use contrast, because that's going to differentiate that nice, heterogeneous, somewhat necrotic lymph node from your vasculature, which is sitting right next to it. So just keep that in mind. Okay, so we're going to move on to the next part of the cases, where we're going to show you hopefully 10, but maybe we won't get through all of them, in which case we could either do this again or you can look at the images online later. But we're going to show you 10 cases of real-life situations from Portland, Oregon. Yes, who knew that we had tuberculosis in Portland? But we do. And if you had a chance to look at the images that we posted online before the course, you'll have a little bit of a head start because we're going to be inviting you to do some audience participation questions. So a little bit of skin in the game, but don't worry, we can't see who's answering, so really just all for fun and to keep you awake. And your CME, CE does not depend upon an answer or a right answer, anything like that. Now, I also will tell you for some of the polling questions, you can give more than one answer, some you can give just one. You know, it's just going to keep you awake a little bit. So, of course, these are my patients, so I have a lot of clinical data about them. But I also gave some of our friends in California an opportunity to submit questions that will help us guide the cases along. Okay? So that's where we're at. So this first film is a little girl, maybe one of my first patients that I met in Oregon. She's a 10-month-old girl. You should be seeing the frontal view here. She's an Ethiopian adoptee, and she came to Portland, and already when I met her, she was already growing and thriving in her new home, and she had a positive skin test. So that's what happens when you're a foreign adoptee. You get screened for tuberculosis. It's different screening now after the 2007 technical instructions, but that's another story. So my California friends wanted to know about some lab tests and exposures, and we're going to start the first polling question now. So go ahead and look at the possibilities for what should we do now. This is the information you have. While you're voting, I will tell you that she had a white blood count of 16.4. She did not have a left shift. She did not have inflammatory markers obtained. And I'll tell you that really when I'm evaluating a TB suspect, and TB is kind of the only question, TB or not, I don't obtain any labs except an HIV serology. That's routine. This little girl did have a negative HIV, and it turns out in backstory that she had multiple respiratory infections or illnesses in the orphanage, and at one point she even received IM gentamicin. She was severely malnourished, and again, as I mentioned, she is HIV negative. So what I can see here is a lot of people want to obtain a lateral view, and you know what that means? That means that Dr. Vu is getting a raise. He reinforced and got everyone to realize that, yes, of course, a lateral view is very important. So I'm going to show the lateral view, and then I'm going to ask Dr. Vu to tell us what he's seeing both between the frontal and the lateral views.
Great. Thank you, Ann. Okay, so the baby lateral view. Now let's review the anatomy again. So you have the trachea coming down. Now you don't see the right upper bronchus very well. The right PA is also not well seen, and the left PA is definitely not seen. And in addition, you see increased density throughout this region of the hilar of the hilum, consistent with adenopathy. Now, if you go back to the frontal chest radiograph, again, this is a low lung volume film, and the lung parenchymal opacity is going to be increased somewhat because of the low lung volume. But if you change the window, as Ann did here, you can actually see a second density near the left hilum. So I think this patient has left hilar adenopathy, maybe a little bit on the right, but definitely left hilar adenopathy. And remember, the vessel along the hilar region. Thank you, Ann. I forgot the arrow. Yes. The vessel in the hilar region are very small in infants. So often you can't see them. Plus they overlap, and then large cardiac silhouette and hilar region. So they are very difficult to see. So what you're looking for is that extra density on the frontal chest radiograph, if you can. Great. Thank you.
I'm going to put Dr. Vu on the spot. I know he's not in his day job a clinician, but she is growing and thriving, and she is cute as a little button. She does have a positive skin test, so does that mean that she does not have tuberculosis? Because she is clinically well. She has no cough. She's growing. She has no fever.
Absolutely not. You have to, the finding is real because you have confirmation on the lateral chest radiograph. You have to figure out what that adenopathy is, and given that she's a baby from Ethiopia, they're definitely concerned for TB, and you have to chase that.
You can now be certified as a pediatrician. Thank you. So I get this question all the time. People say, but she's clinically well. And I'll say, in the United States, about half of the time when we have a patient who even has confirmed tuberculosis, they are asymptomatic. So do not let that dissuade you from considering the diagnosis. So I think a lot of you heard me talk before. Maybe you've seen some of the products. You probably know what I did next. I obtained gastric aspirin. And if it's not something you're used to doing, you can go on our website, which we like, or you can even YouTube it, and you can see a child actor, that was my son, pretend submitting to a gastric aspirin. So this is when we put a little tube down into the stomach through the nose after the child has not eaten anything or drank anything for 6 hours, ideally after an overnight sleep. The classic strategy is to do 3 first morning gastric aspirins, and the highest yield is on the first specimen. So in this case, drum roll please, this adorable little girl who was thriving in her new home in Portland grew multi-drug resistant tuberculosis. Mm-hmm. And we started the regimen, and you can not see on this x-ray, but we had to use intravenous therapy traditionally, including an injectable drug and fluoroquinolones, and usually 4 or 5 or 6 drugs in the beginning of an MDR regimen. But I'll just tell you that there's a lot of exciting changes in MDR treatment, including shorter courses, and even in children, some discussion internationally of using no injectable drugs, so stay tuned for that. So this is her film 4 months into treatment. We're going to have lots of sequential film, so I don't want to torch you too much with this one. Normally, normal regimen, I obtain an x-ray about 2 months into therapy, and we'll show you that in a minute. But in this case, I think that you can see that her adenopathy is maybe involuting a little bit, which again, I'm going to show you more patients. It not uncommonly takes quite some time for the lymph nodes to resolve. And then I'm showing you 3 sequential lateral views here, where you can see on the left, before treatment, really pretty lumpy, bumpy lateral, and then over the course of time, she's definitely involuting that lymph node disease. And in MDR disease treatment, we also repeat x-rays 6 months and about every 6 months for 2 years after treatment, because we all know that MDR is very hard to treat, and so it's not uncommon to relapse. And kids can get lymph node disease from other things. So at least on one of those images, she had a little bit of blossoming on the lateral view, and her parents and I were nervous for a while, but it involuted again, and she's clinically thriving. So she's doing just great. Okay, so here's our next case. This is a little 3-year-old girl who actually was just a couple months ago here in my hospital. This is her frontal view, and we can bring in the polling question. And the polling question says, what piece of information will help you take the next step? And I think on this one you can choose as many as you like. And while you are voting, I'll tell you that my California friends wanted to know her lab testing. Her white count was 15. She had 72% neutrophils, no bands. Her SED rate was 91. Her CRP was 79, and at my hospital, 79 milligram per deciliter. In my hospital, a normal is up to 10. Wow. I also got the question, does she have any peripheral eosinophilia? And the answer was no. Does she live in the central San Joaquin Valley of California? Could she have coccidioidomycosis? And the answer is no. She lives in Portland. She hasn't had any cocci exposure. Does she have any medical comorbidities like congenital disease? So that's a great question. I guess Dr. Wu, we could ask him to comment on that. But when we see something sort of circular like this, we ask the question, could she have like a bronchogenic cyst or a pulmonary sequestration or something that might have become infected? No, there's no reason to think that she had anything like that before. In terms of TB risk factors, she was born in the U.S., but she certainly has traveled to Mexico, and the last time was about a year ago, but the family didn't know about any specific TB exposure. So I'm looking at the polling, and I think all of you can also see the polling results, and I see a lot of people want to know about a lot of these things. Duration of symptoms. So interestingly, her family actually said that she's had some intermittent cough, fatigue, anorexia, maybe weight loss for a couple of months. So when I first heard the story, I thought, oh, really unusual to have a cavity with tuberculosis in a 3-year-old, but that duration of symptoms makes me want to be very careful. Again, she traveled to Mexico a couple times, but no specific TB risk factors, and I will ask Dr. Vu to comment on her images.
Thank you, Anne. All right. Let's begin with the frontal chest radiograph. So as everyone can see that the patient has a large consolidation, very mass-like consolidation in the right middle lung region. Now, the interesting aspect about this consolidation is that it has an air collection in the superior aspect of the lesion. Now, to me, that looks like an air fluid level, and that suggests to me that this is a necrotizing pneumonia with progression to abscess formation. Typically, infant TB consolidation do not cavitate. They can, but typically they do not. And with the presence of an air fluid level, I would worry that this is actually a bacterial abscess rather than a mycobacterial infection. And on the lateral, again, this is done upright, and again, you're seeing a large consolidation in the posterior lung, and again, the air fluid level that you can see here suggests that this is a bacterial abscess. Now, I don't think you can exclude TB in this setting, and I would still proceed with obtaining clinical information to rule out TB, but radiographically, this is consistent with a bacterial abscess.
Great, thank you. So, basically that's the same thing I said. My partner called me and asked me to look at these images one Friday night, and I said, And again, because she had this 2 months of symptoms and the travel to Mexico, so I came in Saturday morning and I taught my partner how to do a gastric aspirate. We got amazing specimen. We got lots and lots of good mucus on our gastric aspirate, and it was AFB smear negative. Now, please remember that pediatric, even in this context, you'd expect a lot of organisms if this were AFB positive TB, but the normal gastric aspirate is almost never smear positive. You have to have about 10 to the 6 organisms per mil on your clinical specimen to be AFB smear positive. Do not make any clinical decisions based on an AFB smear in a child, whether you're looking at a gastric aspirate or induced sputum. They're almost always smear negative. And we also obtained both a quantiferon and a tuberculin skin test in this child. And the reason is because really the stakes were so high in this context. Both the TST and a quantiferon or the IGRIT test are about 80% sensitive in this context early in the disease diagnosis. And so if either one of those was positive, we would have thought, this has a decent chance to be TB, and we might have treated this patient for TB. The other thing I like to do is test the family. So if the family has a whole bunch of positive skin tests, and we have this other epidemiologic data to suggest this is TB, then I would treat also. So in her situation, her AFB smear gastric aspirate was negative. Again, I got lots of great specimen, and if this were TB, maybe it would have been smear positive. Her skin test or quantiferon were all negative, so we treated her for staph or strep disease, which are most common causes of necrotizing pneumonia and lung abscess, and she got clinically much better within just a few days, and her CRP, as I mentioned earlier, was elevated. Again, I don't normally obtain the inflammatory markers in TB because they can be all over the place, but her CRP declined beautifully. So we think of, if we're correctly treating a source of inflammation, we think of a CRP dropping about by half, maybe 18 to 24 hours, and that's exactly what happened with her. So we concluded that this was much more likely to be staph or strep disease, and we're going to watch her over time without TB treatment. So thought that was kind of funny and fun, and that was just this winter. So our next case, by the way, so even though we're going to ask you to hold the questions to the end, I think, and Jeannie, correct me if I'm wrong, I think that you could put questions in the chat box now, so maybe you don't forget them. And if you do that and it's about a specific patient, please reference the case number so that we can sort of go back and think about it. Okay, the next patient is case number 3. This is an 18-month-old who's evaluated during a contact investigation of a contagious adult case. So my friends who submitted questions said, tell me more about that infectious case. Was it a household member? Turns out the source case is her dad, who she lives with, and he is 4+ smear positive. And if some of my friends from Washington County are here, they will remember that he was smear positive for a long time, and he had been coughing for 2 months. So when Anne is saying, is this TB, I want you guys all to think, show me a lateral. So this is the lateral view. It turns out that Dad has not been back to Mexico for about 10 years, but he did come from Mexico. The little girl has never been to Mexico. He was screened about 20 years ago. So it's time for a polling question. So the polling question says, where do you see an abnormality on these images? So here's the lateral. I think on this one you can also have more than one choice. There's the lateral. There's the frontal. What are you noticing? And just a little more background. She had fevers for about 2 weeks, and the fevers had become daily for about a week with anorexia. She had a little bit of viral respiratory type symptoms with runny nose and cough, and her tuberculin skin test was 18 millimeters in duration. And I did not order any blood tests on her except HIV serology, which was negative. So it looks like a lot of people are answering. So I'm going to ask Dr. Wu to teach us about the findings on these films.
Great. Okay. Thank you, Anne. All right. So on the frontal chest radiograph, if you follow the cardiac mediastinal contour, so here's the cardiac contour, very smooth. And as you come up, you start to lose that mediastinal contour. And then just lateral to that, you see lumpy, bumpy opacity. Just lateral to the, now this opacity could be in the lung, or it could be adenopathy. It's very difficult to delineate that. On the left side, you see some cluster of vessels. Difficult to say if there's anything there. Let's move on to the lateral. Okay, so on the lateral, again, you see the trachea coming down. You do see a lot of tissue anterior and posterior to the trachea. In fact, you can see that the tissue sort of encroaches into the airway, or at least extrinsically compressing the airway a little bit there. Again, you don't see the right upper lobe bronchus, the round right upper lobe bronchus. And then you see additional tissue in the region of the right PA as well as the left PA. In the infrahilar region, there are also increased density, so the findings are fairly consistent with adenopathy, likely to be just on the right side.
Okay, so it looks like a lot of people are getting to be expert at the interpretation as they have a lot of correct answers. So I think you probably know by now with this story between the classic radiographic findings, the strong exposure history, the classic clinical picture, she definitely would get started on 4-drug TB therapy by directly observed therapy. I think there's always a lot of discussion about whether she deserves a gastric aspirate since we had really high quality specimens already cooking from Dad. And I usually like to collect at least one gastric aspirate from all my pediatric TB suspects. Because I have had situations, not as strong an epidemiologic link as this one, but I definitely have had situations where the pediatric case turns out they were not linked to the presumed source case. And I've had kids whose TB isolates had different susceptibility patterns. And these are reported in the literature as an homage to my friend Jeff Stark. Maybe you're even listening. That is not common, but my general practice is often to do one gastric aspirate on somebody who has a presumed source case, and more if they don't have a source case or I'm concerned about drug resistance, or if I have any concern that they don't have high-quality specimens in the lab from the presumed source case. So in this case, she started on 4-drug therapy, and when her dad's isolate was found to be pan-susceptible, we stopped her ethambutol, and then she continued on 3 drugs. And so as is my practice, I usually obtain repeat images at about 2 months into therapy. This one got filmed a little bit early, and I can't really remember exactly why. So at that point, she was tolerating her TB meds. She had a little bit of noisy breathing with exertion, but she was gaining weight. And the history that we got is that she really was getting every drop of drug by directly observed therapy with good doses, and Dad's isolate was pan-susceptible. So what are you seeing here, Dr. Wu?
Okay, so this is 6 weeks into TB treatment. You see a large consolidation on the right side, very much like the bacterial abscess case that we saw, which is unusual. And then on the lateral projection, one second, sorry, my arrow. So on the lateral projection, I think you see the outline of the consolidation overlapping the hilar region right there. So therefore, it makes evaluation of the adenopathy on the right side difficult because of this overlap density from the consolidation. Now, the consolidation, depending on the clinical symptom, the consolidation should certainly be from a post-obstructive process, such as atelectasis or possibly post-obstructive pneumonia, where the trapped mucus gets infiltrated and gets superinfected.
Thank you. So my rule, because it is super common to be in this situation where the radiograph is worse. So I have a strategy. I tell the family before I obtain the test radiograph that it's not uncommon that it's worse. And I do what I call running the list. So how is the child doing clinically? Are they gaining weight? Are any respiratory symptoms improving or worsening? Are they having work of breathing? Are they getting every dose? Are we confident about the susceptibility pattern? Have they grown? And now in the littlest kids, sometimes they literally outgrow their dose in a matter of 2 months. And so I run that list. And it is a common situation in pediatric TB that you get this in lymph node enlargement in particular during the course of treatment, and it's associated to the immune reconstitution. And as Dr. Vu said, we can't tell for 100% in this case whether there's any enlargement of the lymph nodes because that adjacent consolidation is a similar density. But if I'm convinced that the child has significant increase in their lymph node size, I usually conclude that's called it's the iris phenomenon, the immune reconstitution syndrome, which we think of more in HIV disease, but is well known in pediatric TB in particular. The way I think about it is as we give the TB drugs, we're helping kill the organisms. And now the immune system, which really had been struggling, and TB is one of the many infections that suppress the immune system. Now that we're helping the immune system can flourish. And what happens is those lymph nodes get bigger. Very, very common. So I don't do anything about it if the child is clinically thriving and they're well and they're not struggling to breathe. But if they are struggling to breathe and they're symptomatic, sometimes I add steroids, always in the context of I'm pretty darn confident about the susceptibility pattern and that I'm treating the correct disease. I would not want to be doing this, adding steroids if I thought that the child had a malignancy or coccidiomycosis or something else. And then if I think that the child has a post-obstructive pneumonia caused by a bacteria, sometimes I add antibacterial therapy. So this is 6 months into treatment. What do you think now, Dr. Vu?
Beautiful. So that consolidation in the right hamlet is significantly smaller. Now it's just a width of consolidation that likely represents some residual atelectasis. The mediastinum is the superior mediastinum is fairly normal for this age group, and that likely reflects some thymic tissue. I don't see lumpy bumpiness as we've seen on the initial study, so looks great. Looks like the patient respond well with treatment.
Right, and so this is a reminder to mention that 60% of the time in pediatric TB with distinctive X-ray features like this, the X-ray is not normal when you have successfully finished treatment. And so you don't have to keep treating until you see a completely normal X-ray, but it should be distinctly better. So sometimes people share images with me and it's like, wow, that X-ray is not at all better. To me, that's a red flag, but don't necessarily wait for a completely normal film. What I do in this case is I repeat films. I repeat a film at 4 months and 12 months because it makes me feel better that the X-ray is gradually improving. If they never had any concern for lateral changes being worse, sometimes I don't get a lateral. I try to save a little bit of money and a little bit of radiation. And having said that, as I was preparing this talk, I thought about it. I can't think of a single case where it changed my management. So maybe I should stop doing that. But again, just a reminder, it is not uncommon for the X-ray to not be normal. Okay, so this is our next case, case number 4. This is a 5-week-old who had 1 day of cough and fever. And in LA County, they asked me about her labs. Her white count was 3.4. She had 20% neutrophils. We did not obtain We did not obtain inflammatory markers. This is her lateral film. You've had a little minute to look at the frontal. Here's the lateral, and it's time for a polling question. So this polling question is wordy, and so it'll take a minute to look at it. Which is most true about the likelihood of TB in this child? And again, this one, you can pick as many choices as you want. I'll be quiet for a minute. So while you're reading and polling, I'll tell you another question my California friends asked. Is this a contact to an infectious case? No. No TB exposure, no TB risk factors in terms of birthplace travel, suspicious contact, nothing. I'm going to flip back to the frontal. And maybe you can think about some of the things that Dr. Vu was asking you to be looking for. And we can ask Dr. Vu to comment on these films.
Great. Okay. Thank you, Ann. All right. So we have a single frontal chest radiograph which demonstrates the normal anatomy. You have the enlarged thymus, enlarged cardiac silhouette. Of note, however, the lung volumes are fairly large in this setting. The lungs are hyperinflated. And if you look closely, I know it's very difficult because the technique is not great, but you see area where there's potential bronchial wall thickenings. There may be a little bit of hazy opacity in the lung up here, but again, that may be due to slight rotation. Now let's move on to the lateral image. So again, this is not a great quality image, but again, you see hyperinflated lung. Look how deep the posterior costophonic angles are. In addition, if you evaluate the hilar region, it looks fairly normal. The right PA looks pretty good. The left PA looks great. There's no increased density. There's no suggestion of adenopathy here. Now, given the findings of bronchial wall thickenings or peribronchial cuffing with a hyperinflated lung in a young child, in an infant or a child, particularly if this happened to present during the winter time where RSV is around, I would call this bronchiolitis, RSV bronchiolitis, rather than TB. But of course, clinically, you have to evaluate the patient clinically and see if there's any risk factor for TB.
Right, so no risk factors. This child was sick for a very short time. Remember, with TB, usually indolent, but on rare occasions can be fulminating. It'd be unusual for a 5-week-old to have TB disease. They'd have to be infected pretty young. So when I think of those two features that Dr. Vu highlighted, the peribronchial wall thickening, we sometimes call that peribronchial cuffing, and hyperinflation, that is bronchiolitis until proven otherwise, often with pneumonia, and there was nothing about this case to make us think of tuberculosis. But I just wanted to remind you that I often get that question, oh, here's some, perihilar infiltrate or peribronchial cuffing cannot exclude tuberculosis. Well, guess what? I exclude tuberculosis in that case. Sometimes what I do, however, if someone was worried and maybe there was a TB exposure or a positive skin test but have those features that look much more like viral, I suggest that we watch the child carefully and then repeat the image in 3 or 4 weeks. And very commonly what happens is the x-ray normalizes because it is a big deal to obtain gastric aspirates and say we're going to start 4-drug treatment. So we really like to focus on the patients who have significant risk of having TB disease. Okay. So case number 5, this is a 13-month-old referred for evaluation of enlarged lymph nodes. So as an evaluation, I mean, these were massive lymph nodes. These were 4 centimeters. And so when I saw her, I did some evaluation. LA County wanted me to get labs. Her white count was 24,000 with 40% neutrophils. And here is her lateral, and it's time for the polling question. Polling questions asking you again to interpret the radiographic findings. Where are you seeing abnormalities? Right frontal, bilateral frontal, lateral, and what do you think, Dr. Vu?
Okay, thank you, Ann. So let's go back to the frontal. Let me grab my arrow. Great. Okay, so again, this is a fairly low lung volume frontal chest radiograph. You can see the contour of the thymus pretty well and the enlarged cardiac silhouette. Now notice that there's a focal consolidation here in the right lower lung, as well as possibly some patchy opacity in the left lower lung as well. Again, we're going to try hard to evaluate adenopathy on the frontal chest grave, and it can be very difficult, but there is an increased density right here, as well as possibly right here. But the finding of adenopathy is not absolute on this frontal chest grave, so I need a lateral, and let's proceed to the lateral chest radiograph. So on the lateral chest radiograph, you see focal opacity. Look like it's involving more of the right middle lobe area. Now again, as we come down on the trachea, you see that the trachea is narrow at this point, and look like there's extrinsic compression from peritracheal adenopathy, as well as hilar adenopathy. Okay, all this increased density, maybe even infrahilar. So this is definitely consistent with hilar adenopathy and focal consolidation in the lung. And I would be very concerned for possibly TB again.
Great. And so my California friends wondered if this child had any TB risk factors. So it turns out that this child was born in the United States, but her family was from a country in Eastern Europe where there's certainly a risk of tuberculosis, but she had never traveled abroad. And so initially with questioning, the mom didn't endorse any particular TB exposures, and it was really only sort of over the course of a long interview did she tell me that the pastor in their church had told the congregation to have the kids in the parish tested because there was a parishioner who had contagious tuberculosis disease. And I don't know where other people work, but we certainly have some ethnic groups here who have a little bit of distrust of public health, and sometimes even some things that we do in Western medicine, like vaccinate. And so sometimes these situations are a little bit hard to sort out. It turned out from this exposure in this church, we had a handful of pediatric TB cases, including a kid who had terrible TB meningitis and wound up with tuberculomas in her brain and really a bad scene. So this person in their parish was highly contagious, and we had a fair number of cases. So turns out her skin test was positive, and we did gastric aspirates on her. And remember, I told you, do not count on the smears being positive, but in fact, her smears were 2 to 3 plus positive, and she had pretty impressive radiographic changes. So we are almost out of time, so I just want to show you, again, she had a repeat film about 6 weeks into treatment. So I have the original on the top left there, and then the follow-up films. What do you think of the follow-up films, Dr. Vu?
Okay, so this is the, let me get the arrow. Where's my arrow? Sorry, okay, so on the follow-up film, the lungs are fairly hyperinflated compared to the previous film. In addition, the right lung is fairly lucid, which to me suggests that there are some air trapping involving the right lung. The consolidation you can see pretty well because of the additional contrast provided by the air trapping. Now the mediastinal contour again reflect some regression of the thymic tissue. The heart is fairly normal in size. Again, can't see any adenopathy at all on the frontal chest radiograph. On the lateral chest radiograph, you can see the focal consolidation and possibly some infrahilar adenopathy that you can't see on the frontal chest radiograph at all. So it looks like there's some improvement compared to the initial chest radiograph. The air trapping may reflect some ball valve effect within the airway or extrinsic compression of the airway from adenopathies causing some air trapping.
Thank you.
And?
So, yep. So, interestingly, she tolerated her TB therapy, but really just a few weeks into therapy, she actually started to have increase in the size and number of her neck lymph nodes, which I told you before were really generous before. Well, they got even bigger. And then at the time of this image, she started to have cough for the first time and fever. And when I reevaluated her, she had significant work of breathing and some decreased air entry. And I agree. I think she she had a post-obstructive process, and in this situation, by this time we knew that she had susceptible disease. We had evidence both on her, in her neck and on her images that she was having some immune reconstitution, and I was concerned that she might be having a post-obstructive bacterial process because she had new fever. And so this is a situation where I did treat her with some steroids and amoxicillin clavulanate, which I think is good for post-obstructive pneumonia because it covers staph, strep, and mouth anaerobes, which are the things that I worry become trapped behind an obstructive process. And fortunately, she did get better. And this is her image 5 months into treatment. How do you like that film, Dr. Vu?
Okay, so you see on this film, you can see that there's suggestion of opacification of the left lung. You can still see the consolidation on the right. Now, when you see a dramatic finding such as these, you have to be careful and evaluate the patient for rotation. You can see that the spinous process is way out here. So this is a very rotated film. And the opacity that you see in the left hemithorax is really just mediastinal and cardiac structure. So I would ask to have the film repeated where the patient is more a better position and see if those are real findings. Thank you, Anne. So on the same day study with better position film, you can see that the cardiomediastinal or the cardiothymic silhouette are now in better position, and that the left lung is fairly normal. And the consolidation is still there. Maybe the air trapping is still there as it's still lucid.
Yeah, and so 5 months into therapy, she was lots better. So interestingly, at that point, 5 months into treatment, her family announced that they were moving back to Eastern Europe. And they agreed to finish 6 months of treatment by direct observed therapy via Skype. And because her disease really had been so extensive, and so strongly smear positive, I was wanting to be a little bit aggressive and treat her longer for 9 months of treatment. So the family sort of made a compromise. They said, we'll do your DOT by Skype until 6 months, and then we will finish your 9 months of therapy, but we're not going on Skype anymore with the time change and every other thing. So that's what happened. And I just wanted to remind you, at this time, I want to say this is maybe in about 2010, we were using a lot of twice-weekly therapy. There's a lot of evidence in the literature, especially in the third world, showing that twice-weekly therapy, intermittent therapy for pediatrics works, directly observed. But our new national guidelines say do not use such intermittent therapy. Again, the guidelines are really for adults. But I have to say, I had a situation a few years ago where patients failed therapy with twice weekly. And so I always do 3 times weekly therapy in the continuation phase. And some jurisdictions like San Francisco always do daily therapy. So again, back then we were using twice weekly. I would encourage you to consider daily therapy in the continuation phase or 3 times weekly. So this kiddo had the whole package. She had exam findings typical for TB. She had the exposure history. She had a positive skin test radiographic, and she was smear positive. Unfortunately, our cases are usually more subtle. And I think those of you who know me know that I would like to go through these other 5 cases that we have prepared and talk all day long because that's what I like to do. I hope some of you are laughing. But Jeannie would be mad at me. So I am going to stop, and we are going to encourage you to ask questions. And so you can enter questions in the Q&A field. I apologize that I was wrong, that you couldn't do it earlier. Or you can unmute your phone by pressing *6. And don't forget, when we're done, to do the evaluation. And if you think this was the best conference ever, my name is Ann Loeffler. If it was a little shaky, Dr. Vu. I hope you're laughing again. Okay? We're waiting for questions.
And let's take phone calls for now. So if anybody wants to ask a question, press *6 to unmute. Thank you.
While people are gathering their questions, I also want to remind you that we consider ourselves to be an important resource at the regional centers. And don't hesitate to reach out to us and ask us your questions via email and phone. We get back to you typically within 1 working day. Sometimes we fall down, but generally we really appreciate being involved in the care of your patients. So anyone on the phone? So I'm just going to answer some questions here, but just say, yo, if you get on the phone. Someone's asking, did the child complete the 9 months of therapy? I have no way of knowing, but interestingly, as I was preparing this talk, I see that she surfaced, and she was actually seen at an emergency room in my 6-hospital system, and unfortunately, my friends who saw her in the emergency room for something completely unrelated didn't notice that she had been followed for tuberculosis, because if they had, they probably would have called me, and I would have said, oh, get an X-ray now. So I can't tell you if she finished 9 months of treatment, but I can tell you she's alive and well and showed up in the ER for like a laceration or something. Dr. Chandler, my friend at Alaska, says, are you regularly using Skype DOT? Maybe I'll ask some of my friends at my county health departments, but I certainly know for some situations after well-established DOT and after we see a pattern that the kid really can swallow it, is not cheeking it, is not spitting it out, is not throwing up a little bit later, that we definitely in some circumstances have good success with Skype DOT. Any phone questions? Youngest age that you rely on IGRA testing results. So I will just tell you, let me see if I can see the rest of the question. Some have used in infancy using MyDignity studies. So this is the way I think about this. The skin test and the IGRA test probably have about the same sensitivity. And IGRA tests clearly have better specificity. And there's a newer quantiferon coming out that may have better sensitivity. It's a little bit different platform. And I would use an IGRA at any age group, and I just acknowledging that no test is perfect. A negative skin test, a negative IGRA does not rule out TB disease, but a positive really helps me. And a group of us have been on conference call. Many of the people passionate about pediatric TB in California, and Jeff Stark, and California has started to say for screening that they prefer the IGRA down to 2 years of age for patients who have received BCG, sort of foreign-born situations. And we anticipate that the next American Academy of Pediatrics Red Book is going to go down significantly on the age for which IGRAs are recommended over skin tests. So that's what's coming. There have been newborns with congenital TB who have had positive IGRAs. So it's all about, the immune system developing. They may not yet have that part of the delayed type hypersensitivity developed, and so it may not be positive, but if it's positive, it's very helpful. Phone questions? I see the question, would you consider doing an expert, and that's the molecular test that looks for the genetic material of MTB as well as rifampin resistance on a smear-negative gastric aspirate. I would tell you, my lab, embarrassing to say, but we don't see enough tuberculosis that we've been able to internally validate in order to publish our results. But my lab, they are saints, and so they'll sort of do anything for me. So I wouldn't hesitate to perform an expert, but it would only be helpful if it were positive. And there's lots of studies using the expert on gastric aspirates. It's better than smear and not as good as culture and not as good as clinical interpretation as the things that we've been talking about. So definitely do it, but I think only helpful if it's positive. Questions on the phone? I see a question, are there medical, licensure, or legal concerns for a physician to treat a patient in a foreign country like this by Skype? Well, thanks for bringing that up. Now I'm nervous. No, just kidding. I would say that where they were going in Eastern Europe, we had no confidence about their ability to get TB care by DOT. And originally, when they first presented to care, they wanted to go back to Eastern Europe because they didn't believe me. And I think people who know me know that I really take really careful care of my patients. So I thought I was giving them good care. So we felt like the option to do at least one more month of DOT kind of was a balance between their distrust of our Western system and, you know, their autonomy as parents. So, yeah, maybe there are licensure issues. I think in the ideal world, like if certainly if the patient was going somewhere within the states, we would have done an interjurisdictional referral even to Mexico. We have lots of relationships there, of course, to, you know, a more developed country with a more robust system. But knock on wood, I don't know. My old friend Patricia in San Joaquin asked, I know it was not presented, but what was the answer to the case of the 15-year-old with hip pain? So some people had an opportunity to look at the cases online ahead of time. So I'll just tell this story. The 15-year-old with hip pain had recently emigrated from Vietnam, and he was seen in the emergency room because this hip pain that had been sort of on and off, a little bit annoying for maybe a year, had flared up, and he had excruciating hip pain. And because the rheumatologists were concerned that he had an autoimmune phenomenon, he had almost complete destruction of the cartilage in that hip. And so they wanted to treat him with high-dose steroids. So pediatricians in the audience, what do we want to do before we treat our patients with methotrexate, high-dose steroids, biologics for autoimmune diseases like inflammatory bowel disease, or even in impending immunotherapy with leukemia? We want to rule out TB disease first. And so they had obtained an IGRA, and unfortunately they did not see the IGRA results before they used the high-dose steroids. And so that first image showed just the tiniest bit of, looked like a scar in the right upper lobe, right in the vicinity of the clavicle. And if we had gotten to that case, you would have seen on the second image we zoomed in on that area to show you, oh yeah, that is not quite normal. So the radiologist and even my partner who was involved at that time said, oh look, there's a little scar. Well, everybody who, you know, really does TB for a living, we kind of pause before we say that's a fibrotic scar, because we've seen plenty of adults in particular who are thought to have scars. If you collect cultures, you actually can find a higher rate of TB disease in those patients compared to someone who's got true LTBI. So this child had this little tiny squiggle on the x-ray and received high-dose steroids, and then we started the process of collecting specimens after we saw the IGRA results, and lo and behold, he grew multi-drug resistant tuberculosis, and the film really blossomed. There were several areas. In fact, I think that maybe even it looks a little cavitary in the area of that alleged scar, and it grew multi-drug resistant TB. And so this has been the most challenging case of my career, and it's ongoing. So he has complete destruction of his left hip. He needs a hip replacement, and he has tolerated TB therapy worse than anyone I've ever seen. So I've never done this before, but after he threw up every dose of TB med for about 3 months, we recently put a gastrostomy tube in. He had lost 11 kilos over that time, and so we are feeding him all night, and his mom is sneaking into his room and giving his TB drugs, and he's back on track for about a month now. His weight is back up. He's back at physical therapy, and he's on track to have his hip replaced in July. And a shout-out to Tyson, his nurse case manager at TB Control in Multnomah County, and everybody who's involved in that case. So, Patricia, thanks for asking, because I wanted to share that story. Jeannie, am I out of time here?
Yes, but is somebody on the line?
Yeah, can we ask one question from California?
Sure.
I was curious, in some of these cases that you shared where the child was very well and there was only intrathoracic adenopathy identified, do you ever consider, I've read that you could do like 6 months of just INH, RIF, or any other kind of less hardcore treatment. Is that anything you ever consider or think there's any evidence for?
Yeah, the Red Book, the American Academy of Pediatrics Red Book has had that recommendation for a long, long time. I think maybe my friend Rich Jacobs in Arkansas likes that regimen, and I wonder if it's in part because in Arkansas and then certain other places like certain parts of Houston. Jeff Stark sees little INH resistance. Alaska, until recently, they saw very, very little isoniazid resistance. And so if you're dealing with an isoniazid susceptible isolate and exclusive intrathoracic lymph node disease and no symptoms, yeah, probably isoniazid and rifampin is enough. And if you think of the natural history of TB in these kids, they inhale the organism. And if you didn't treat any of them, a lot of them would involute to LTBI. And back when we first were studying isoniazid, not we, because I'm not that old, but kids who had modest radiographic changes and really essentially asymptomatic, they were treated with isoniazid alone, and 90% of them did fine. So in the United States and really in all developed countries, we think 90% is not good enough for our kids with TB. And so that's why we treat with multi-drug regimen. But absolutely, I have no doubt that treating with isoniazid and rifampin alone is going to probably successfully treat isolated hilar adenopathy if it's drug susceptible. And when I lived in California, I found a good number of kids with isoniazid resistance. I had a 6-year-old that I was able to induce sputum with a sputum induction process, and I got that she had isoniazid resistance. And I had 2 cases where initially we didn't identify the susceptibility because we didn't have a source case. It's a long story, but kids got treated with 3 drugs, and they failed. So, yes, most of the time, you'll be fine. And sometimes you won't if you have isoniazid resistance. So I hope that answers your question. I don't tend to do that, but sometimes I fudge a little bit, like if I, if the X-ray findings are not compelling, sometimes I have used isoniazid and rifampin. I don't do that routinely. I usually use 4 drugs because I don't want to be in that situation where I go back and things get worse, and then I'm asking, did I amplify drug resistance, which is not common in pediatrics, but that's who I am.
Thanks.
Yeah. So Jeannie, I can't remember. Should we answer some more of these questions?
Let's answer the questions. I think LA will probably log off by now since they have their conference, and I would like to thank them for suggesting this topic in the first place. Thank you very much for that. So let's move on with the questions.
And by questions, do you mean answer some more that are in the box, Jeannie? Is that what you mean?
Yes, unless other people have any further questions on the phone.
Okay. So I'm looking at some more of the questions. So it says, was case 10 a true TB case, and if so, what site? And I think that's the case that we just mentioned. That's the boy who had multi-drug resistant tuberculosis in his lung. I didn't mention that we did biopsy his synovium and aspirate the fluid, and we looked with AFB culture. We looked with PCR. We did everything we could and could not find TB in his hip, and he was HLA-B27, so we concluded that his hip was his autoimmune disease, a JIA variant, and his lung process was MDR-TB, culture proven, blossomed on steroids, and his X-ray is now normal, and he's doing well. Let's see. Trying to scroll down. It's a little bit hard for me to scroll. Karen says, no questions, but I have to say you were both great. Good job, Dr. Vu. You see that one? And Genevieve out at St. B's, poor audio. I'm sorry about that. Gosh darn it. Down to what age again? Is the question about IGRA testing. Again, I would personally use it at any age if I'm looking to evaluate a child who's a TB suspect. When I'm doing it for screening, I don't screen. I'm not a real pediatrician. I don't screen kids normally. My personal thing about IGRAs is I'd be happy if people started to just use IGRAs and not use skin tests down to about age 2-ish. When the child has received BCG or lived in a foreign country and probably received BCG, And then when kids come to me and they have LTBI, the question is always, I don't believe the skin test result. And everybody in my country has a positive skin test and nobody has TB. So I go over all of that. I use a little Catholic guilt. I tell them, you'll feel really sorry if you don't treat, and then they're a young mother and they activate their TB and they infect your little grandbaby. But if this blood test will help you make a decision, if it's positive, I'm really going to ask you to believe that it's true and treat your child. And if not, well, then I could be on board with watching your child carefully and seeing if they activate their TB disease. So I hope that answers the question. I will use an IGRA test at any age, but I think that we're kind of the place where about age 2 is where we should be using it more traditionally for screening. But I know that's an ongoing discussion, and I know Jeff Stark is literally in the process of writing the next version of the Red Book at this point right now. Patricia says, Bright Future recommends TB screening at 1 month, 6 months, 1 year. What is the earliest to do a PPD? So in terms of when to do a skin test, I don't know about Bright Futures, but I know what the national guidelines say is no administrative skin tests or IGRAs at all. Only do questionnaires looking for risk factors or screening when a child has TB exposures, and otherwise screen them by questionnaire with every well child visit, and more ideally not start skin testing until maybe about 6 months of age. But certainly you can do it at any age. We just know the younger you are, there's less likelihood that your delayed type hypersensitivity part of your immune system is fully developed. So you're definitely going to have more risk of false negatives in the youngest age group. But if they're positive, they're always helpful. How do your pediatric patients tolerate side effects? And I would say 9 out of 10 really have no side effects. It's mostly a nuisance, figuring out how to get the drugs in. One of the cases that I didn't show is a little girl from Chook, or her family's from Chook. She's born in Portland, and her mom has it down to a science. And Bruce Chandler, every time they come in, I think about you, because mom brings her pill crusher, and the only reason they're doing it, they do their DOT when they're seeing me for a clinic visit. And mom gets out that isoniazid, she jiggles open the capsule of their FAMP, and she crushes them together, and she drizzles in a little bit of simple syrup, and she, gives it, and she is masterful. She puts a 1/4 ml in. She waits till the kid swallows. And maybe she gives a little sip of whatever the kid has in the bottle, which I don't want to talk about because she's getting to the age where she probably shouldn't have a bottle. And then little by little, I see that pill crusher, and I see the mom getting every drop of med out of the pill crusher, and I think, wow, you're amazing. And at the point I would have said, ma'am, you got 95% of it. Nope. She goes in with a couple more drops of simple syrup. She moves it around, jiggles it around until the kid has every drop. And she is just doing amazing. And if people are wondering why I'm mentioning Bruce Chandler, because his family funded a foundation, and one of the things that they do is they supply pill crushers to people in developing countries who their kids literally couldn't afford to have that advantage for dispensing their TB meds. Lots of exciting things about TB medications coming. There's formulations in other part of the world that hopefully will be coming here before too long with more tolerable and combination drugs in suitable ratios for kids. But generally, I have a lot of success and not a lot of side effects. Erica says, so do we not depend on radiographic improvement for clinical confirmation of pediatric cases? Very, very good question, because, the CDC criterion are clinical case 3, so clinically improving or radiographic improving. Well, ironically, I sort of think the other way. If they have that immune reconstitution phenomenon where their lymph nodes in particular are getting bigger, but they're clinically improving, I go, yep, that was TB all right, but I run the list. Are they getting every drop of med? Are we confident about the susceptibilities? Is it the right dose? Are they otherwise well? Are they growing, thriving, not struggling to breathe? So I run the list every single time. And so then it's a clinical class 3 based on clinical, and you might have to wait several more months to see the radiographic improvement. So that's a great question about the CDC classification process. Susanna asked, we have always hospitalized children who need gastric aspirates. Do you have a sense of how common it is to offer this procedure? I assume that means as an outpatient. So I think many of you know that since I used to work at Oakland Children's, where I learned everything I know from those patients and those clinicians in California. Amazing time in my life. And in Oakland, the Medi-Cal would not pay for the kids to be admitted for gastric aspirates. So before I went to Oakland, I didn't make this up. They had the families come in to like our little day treatment area and obtain gastric aspirates, and we had about a 40% yield, which goes along with the literature rate. Now, we had a little higher yield when they were admitted to hospital, but those were always the sicker kids with the more extensive disease. So I don't know how many places are doing outpatient gastric aspirates, but I will tell you that I have friends who have practiced elsewhere, like in South America, who say, Ann, please don't be saying that it's a good idea to do outpatient gastric aspirates because then people won't pay. And in other parts of the world where there's no way that they could get to a clinic in a timely manner, because remember, the kid has to be NPO. So what I tell the families is bring them in their jammies. Do not wake them up. Do not get them a single sip of anything to eat or drink, and sneak them into the clinic. Because once they get anxious or once they eat, their stomach's empty and you don't get a gastric aspirate. And I personally think that's why you get 90% yield on the first specimen, and the yield markedly diminishes after that. So I don't know how many other people do it, but it works well for me. I really admit the kids when they're symptomatic, which is pretty rare. I see someone from Erie, Pennsylvania. I trained in Pittsburgh, so hi to Pennsylvania. Genevieve is asking about TST or IGRA, and I would say it's the same thing. I feel like the sensitivity is about the same, and the impact of the young age is about the same. So when you're very young, the skin test can be a false negative. The IGRA can be a false negative, helpful if it's positive, less helpful if it's negative. There's some administrative questions. Says, how does gastric aspirate compare in sensitivity with induced sputum? That's a great question, Greg. So I think we have some references on our website about that. And this is the way I look at it. There's a group in South Africa that has really, I think, been a big proponent of sputum induction, and they get better yields than they get with gastric aspirate. And there are other people in the country who, so I get about 40% yield typically with gastric aspirates, but I'll admit, I really, I do gastric aspirates on the littler kids because they're higher yield. A toddler who just has hilar adenopathy, they're almost never going to have a yield, so I cherry pick a little bit. But the South African data suggests sputum induction is better, but it takes a long time. So what they do in those little kids is they'll treat them with a bronchodilator first, because when you do sputum induction, you sometimes send them into bronchospasm. So they do a bronchodilator first, and then they use the nebulized saline, like a 7% hypertonic saline, and then they start them coughing. And if they're old enough, they cough it out. And if they're not old enough, they slip a little tube into the back of their nose, into the posterior oropharynx, and they try to collect the sputum as the kids are coughing it up. Well, I guess I am just too darn lazy for that, because it's a whole lot quicker for me to just slip the tube down the nose, just like they're doing, keep going, put it down into the stomach, and collect the mucus. So I personally think that a well-done gastric has as good a yield, if not better. And I wonder, just looking at some of the details of their procedure, I wonder if that accounts for it. But I think that I think it depends on your clinic and your success, and you should do what you do well at. And then it says that, great webinar. I hope you can send the answers and discussions on the rest of the cases. It was really great. So I think that's a good time to wrap it up and to say, I think Jeannie will tell me what to do, because I need Jeannie for everything, whether we send out these cases as is or how we handle it. So that's all I know for now.
For the cases? Are you talking about the cases?
Yeah, so Patricia suggested that we could send out the
answer.
yeah, some of the case details.
I think maybe in the future we might have that second part of the webinar, but this is still not like 100%. So maybe we could provide her with the first 5, and then if we decide to do the other 5, then we could have the webinar and provide them with the material.
Sounds good. Or Patricia, you can always email me, or we can call. We can always talk. All right, so we're going to wrap it up, Jeannie and Kai?
Yes.
Yes. So I'm going to talk about, thank you, Anne and Kai, for doing this wonderful webinar. We really appreciate your time.